ClinHaem, Haematology, Demystified.
Okay, so I will just briefly cover ITP as well. And this is, of course, being recorded, so you can watch it later. So the layout is similar. Definition, diagnosis, differential diagnosis, treatment, but no complicated business like in IHA, as we mentioned. I don't need to tell you the definition, but this is can be newly diagnosed or persistent, which is 3 to 12 months, or chronic when it is more than 12 months. It is acquired immune-mediated thrombocytopenia. Diagnostic process, you rule out other causes for low platelets because ITP is a diagnosis of exclusion. And if you think this is ITP, you rule out secondary causes that can cause ITP, like secondary IHA. So as you would know, if you are a senior enough trainee, or at least in the second year of training, you would have seen a patient with ITP. You know, we don't test everything under the sun for these patients, but on the left, this is a minimal checklist that you need to check, starting from patient and family history, especially to rule out things like inherited thrombocytopenic syndromes, and definitely check a previous platelet count, because you need to make sure this is not just an inherited platelet deficient problem becoming apparent in adulthood. Examination, again, for obvious reasons. You check a reticulocyte count as well to make sure they're also hemolyzing. Blood film, again, the most important test for any hematological problem, and this will give you an important clue towards the diagnosis for the cause of thrombocytopenia. A basic virology screen and hematinics are important. Immunoglobulin level are measured, especially if a patient is a young adult or a child, to make sure they haven't got immunodeficiency syndromes, etc. Now, additional testing for those where it's relevant. So, in the appropriate geographical settings, you want to check for H. pylori antigen in the stool, for example, because sometimes the ITP is because of cross molecular mimicry to H. pylori antigen, and you want if you treat the H. pylori, it actually treats the ITP as well. If there is suspicion of antiphospholipid antibody syndrome, for example, from SLE causing secondary thrombocytopenia, you look for antiphospholipid antibodies as well. Anti-thyroid antibodies, because ITP is an autoimmune condition and it has been seen in association with many autoimmune problems, especially thyroid problem, and thyroid function on its own as well, because it can cause low platelet count anyway. If the patient is a young female capable of childbirth, the pregnancy test, not only because even if this is ITP, you have got treatment implications, but also there are other pregnancy-related causes that could cause thrombocytopenia. If suspected autoimmune disease are there, then ANA, virology PCR if they're suspected, that if you also suspect hemolysis. Bone marrow biopsy is not required in all cases, but it will be required if you're suspecting other causes, to rule out other causes from suspicion, for example, from the history exam or the full blood count findings or film, or if there is no response to treatment or a relapse of ITP. So now the glycoprotein antibody, specific antibody, are those antibodies which are implicated in the to be a target of the autoimmunity in ITP, but they are not great tests to do because of the specificity and sensitivity, which isn't great. So we don't do that routinely at the moment, only in very specific scenarios and done at very few centers. So differential diagnosis, which is the causes for thrombocytopenia. Again, I would like to divide them into inherited versus acquired. Inherited is inherited thrombocytopenia syndromes like Bernard-Solier, etc., or TAR. Acquired could be from decreased production, which is bone marrow disorders like MDS, aplastic anemia. Liver disease can cause it from various mechanisms, a low platelet count, including hypersplenism, but also simply because there is not enough thrombopoietin being produced from the liver. B12 folic acid deficiency causes cytopenias. Thyroid disease can cause it. Or the other thing is peripheral destruction, which can be from ITP or other secondary causes. Drugs can cause it, especially alcohol. Quinine in tonic water, again, a good exam question, can cause thrombocytopenia, and you have to advise them to stop doing that. PTP is an important side effect from transfusion reactions and very important for exam again as well. Now, lastly, hypersplenism can also cause low platelet count. So this is again a very easy exam question and scenario, and I'm sure you already know all of these causes. The treatment goals in ITP. Now, is quite individualized to patients, and the aim is to prevent severe bleeding episodes. The platelet cutoff normally quoted in the guidelines would be to keep the platelets above 20 to 30, at least in patients who are symptomatic, say with superficial bleeding, say mild bleeding into the skin, bruising, purpura, but especially if there is wet purpura, which is basically bruising, hemorrhaging inside the oral cavity, or if the patient is high risk for other reasons, like if they're on blood thinners, for example, they require anticoagulation, high risk for falls, etc. So it has to be individualized, but generally in adults, we will try to keep the platelet count above at least 20 to 30 in the absence of bleeding or with minimal bleeding. Of course, if the bleeding happens, you have to raise the platelet count to a specific target depending on where the bleeding is and how severe it is. Or the other indication would be to raise the platelet count if they're going to have a procedure to a safe level for the procedure. But very important and definitely should be mentioned in the exam, but also in real life, you have to give minimally toxic treatment to maintain good quality of life because that's very important. And some thresholds quoted in the guidelines, so PIC lines, etc., can go in if the platelet count is more than 20 in the right hands, lumbar puncture for 40 and above. So any major bleeding or major surgery, usually 50, but neurosurgery or neurosurgical bleeding or procedures, we need more than 100 because we're very high risk for obvious reasons. And this slide summarizes all the treatment for ITP along with the response time where you start to see the raise in platelet count. So for acute treatment, you use steroids, similar to warm IHA, so 1 milligram per kg PRED, for example. And if you don't see a reaction or don't see a response or in 3 weeks or so, you try to taper it down quickly. But if you do see a response, then you taper it down slightly slower. IVIG is an emergency treatment that can be used to quickly boost the platelet count. NTD is not used much in the UK, but the rationale is if the patient is RHD antigen positive, you give NTD. NTD will coat the patient's red cells and will trick the immune system to try to eat up the red cells instead of platelets for a bit, and you will see a rise in the platelet count. But of course, you risk hemolysis. Subsequent management, if these things haven't worked, and of course, there are two options, TPU analogs or rituximab. Most people would now favor TPU analogs because of this, ease of use, etc. Oral ones are L-Trombopag and Avatrombopag. L-Trombopag has got dietary restrictions, so no dairy products and multivitamins, etc. Few hours before and after. Avatrombopag does not. Tomiplostim is a subcut given once a week or so. Another option is rituximab. Usually people would prefer that if the patient is young, female, has like an autoimmune kind of a background like SLE and things where it might actually be required for those problems anyway as well. And the response is quite good in them. But this is an option. A third line, which is nice, a nice approved option is fostamatinib. So this, prevents, acts on the spleen, tries to prevent the platelet uptake in the spleen. One important thing to note for that is it can cause high blood pressure, etc. So have to keep an eye on that. Other options are similar, as you can see, to IHA because this is warm IHA because this is again an autoimmune disease. Splenectomy again, not very liked very much. But if and everything has failed, etc., you at least have to wait for good few months, and you have to have important implications for vaccinations. There's a test that you can do at some centers to check if the spleen is actually responsible for significant chunk of platelet uptake. This is Indian labeled based autologous platelet scanning, which you can do prior to splenectomy to make sure. Not a lot of centers would, of course, do that. In emergency, again, you would do A to E assessment and management. What you would do is you would give everything you have, which is IVIG, steroids, and platelets. So a patient has ITP and unfortunately had intracranial bleeding, for example, you will give everything. Platelets don't normally work in ITP, as you know, because autoantibodies are already sat there. And if you give, which are quite non-specific actually. So if you give platelets, they will just mop up those platelets as well. And you won't see a much very nice platelet increment. But in emergency setting, you want to give everything that you can, say in intracranial bleed. Other options to add on include tranexamic acid and sometimes emergency splenectomy again lower down the line. Target will depend, as I said, on the site and severity of the disease again, severity of the bleeding again. A patient has multiple relapses. The most important point is to reconsider the diagnosis because this was a diagnosis of exclusion. So you do a bone marrow biopsy, look into other causes, inherited causes, genetic tests, etc. If you can't find anything, you, of course, side by side, you will assess compliance and dosing as well. And if you're sure this is ITP, you move on to the next lines. Briefly about ITP in children, one thing it will do is it will scare you when you go into the PEDS rotation because the platelet count does drop into quite low levels and it is quite individualized in there. And because there's a very high remission rate in ITP in children, most guidelines will suggest against immunosuppressive treatment, which is steroid, even when the platelet count drops at a very low level in the absence of bleeding, because most of them would just resolve on their own and you spare them from steroids' nasty side effects. So that's why they usually favor monitoring unless quite severe grade 4 bleeding, etc. But remember to especially exclude inherited causes, immune deficiency syndromes, and events for which a slide is coming briefly. In peds, what they do is they would do a bone marrow biopsy at 3 to 6 months if there is no recovery, because as I say, most of the ITPs would recover, and a patient won't have any problem from that. But they want to do a bone marrow to rule out other causes after a few months. Treatment is, if is needed, it follows similar principles with steroids and etc. Splenectomy is avoided in children, especially if they are young, under 15, under 5 years of age, and if the disease is within 1 year, same because as I said, it might just resolve and you can spare them from long-term consequences of splenectomy. Lastly, events is everything combined that I have talked about today. So IHA plus ITP is events, and it can be primary without any known cause or secondary to anything like a SLE or cancer, etc. But actually, 50% or more also are neutropenic. You especially want to rule out autoimmune lymphoproliferative syndrome, as I've said previously, with the flow cytometry checking for peripheral T cells. And in this case, you would see T cells which lack CD4 or CD8, as I've mentioned. So the T cells would be lacking both of them. Normally, T cells are supposed to have CD4 or CD8 on them. Treatment is complicated, but follows similar pathways for both of them. Some people will try to use omeprazole, etc., or TPO analogs to at least target the ITP side of things. So there is events, and that's one of the resources that I've used here for this talk. And finally, it brings us to the end. I know this was quite a lengthy session. This is because were important concepts in there. Most of the other topics will be straightforward, and I will try to finish them well within time. Any questions? Otherwise, I will stop the recording, but we can still stay and have a chat if you want to ask questions afterwards or in the chat.
Yeah, thanks, Asnan. That's a good start. Um, if you want, you can stop the recording. I could ask a few questions if that's all right, or whatever
Yeah,
you
of course,
feel.
that's fine. Perfect. I'm just doing
Yeah.
that. Thank you very much.
Yeah.
Okay.
Thank you for watching. Stay tuned for more.